So much of medicine is like this, blind men and the elephant, right? If you ask a gynecologist or an infectious disease person or an ENT doc or a cardiologist, you might get a different answer, right? Because everybody's looking at something with a little bit of a different angle. And we're going to use that analogy for blind men and today's subject, because what we're going to talk about can be considered as money, it can be considered as medicine. Some people say it's life-saving, some people say it kills people, others say it's a preservative or a flavoring. And what is it that we're going to talk about today? We're going to talk about salt. Now, it doesn't sound like salt would be something that would be an advance in cardiology. But it turns out that salt has been historically a very, very important substance for millennia, literally. And there are still huge unanswered questions about something as simple as salt. I have no conflicts regarding this particular thing. I don't work for Leslie Salt Company, that's it. So when we use the word salt, okay, not all salts are what we're going to call salt for purposes of today's talk, right? Salt, if you look up the dictionary definition, this is what it is. It's a chemical compound. It consists of a negative and a positive ionic charged compounds which get together and form a substance. So there are many, many different salts. Going back to your high school chemistry, you're all familiar with the periodic table of the elements. And basically for salt, you take one from one of the two left columns and then one from the second to the right column, and you combine them to make a substance, which are quite familiar to all of us. And the one we're going to talk about is salt sodium chloride, okay? You better now? Okay, thank you. So not all salts are the salt we're going to talk about, right? You can use Epsom salts. Those are made of magnesium, right? So if you need to move your bowels or sit in a bathtub, that might be helpful. You can use calcium chloride, a different kind of salt. Dr. Pappas may need this for her driveway. Here in Santa Monica, we don't need ice melt here since it's never snowed in Santa Monica. You can use smelling salts, which are not salts at all. They're ammonia, and why they're called salts, I have no idea. And I am going to actually present some data about the use of a salt substitute, which is a different salt, mostly. It's potassium chloride instead of sodium chloride. And we'll touch on that with one of the big articles that has come out in the last year. But our salt is sodium chloride. Here it is. And 1 gram of salt contains about 388 milligrams of sodium. And there's a little, when you read about how much salt is it safe to eat or how much sodium, remember that salt is sodium chloride and then other things too. So when you buy table salt in the United States, most of it has iodine in it. And if you buy salt that says Himalayan salt, for example, Himalayan salt is sodium chloride, but it has other substances in it as well. So there's less sodium per, say, teaspoon of Himalayan salt than there is of what you and I would call table salt. But in general, 1 teaspoon of what you would purchase at the supermarket of table salt has about 2,300 milligrams of sodium, elemental sodium. And that is what is recommended, and we're going to delve deeply into where did this recommendation come from? Is there legitimacy in terms of should we avoid salt? Should we take more salt, less salt, no salt? That's what we're going to try to answer today. Now, if you're a physical chemist, you'll look at salt as 2 substances combining with enthalpy and charges and things. We're not going to delve into that. If you're into this, you're in the wrong room because this is a medical talk. The bacteriologists view salt in a different way, and in fact, for over 6,000 years, salt has been used as a preservative. Why is it that bacon can last a long time, for example? It's because it has a lot of salt. And if you have a lot of salt, and it could be this kind of salt or any other type of osmotic pressure, what you do is you desiccate bacteria, and this is why salt can work, because it sucks water out of cells and kills things like bacteria. We're not going to discuss this as a preservative because hopefully you're not going to have the water sucked out of you by the salt that you use. Cooks, of course, use salt, and I was once on a circuit giving lectures with chefs in various cities around the United States, and when I asked them why they use so much salt, it's because they said, nobody will eat my food if I don't salt it. Right? And that's why salt is so prevalent. Yes, for pickles, for example, it's used as a preservative, but most of the salt that you're familiar with in salty foods is there because there is a palatal benefit of eating salt. We all enjoy the taste of salt. In fact, we'll talk about that later when we talk about heart failure. If you're an alternative doctor, you'll say something like this: your body needs salt. And in fact, I'll blow up what this gentleman says here. Recent studies have linked low sodium intake to diabetes, flagging metabolism, heart disease, decreased cognitive ability, none of this is true. But there are elements of truth to this, and I'll show you where these types of erroneous statements come from. If you're a public health official, you'll say something like sodium is essential, right? You must have sodium. But consuming too much can lead to health complications. And indeed, that's where the public health recommendations that we're going to pick apart here in a moment come from. You can say too much salt kills people, right? That's one of the blind men and the elephant. You can use salt to cleanse your colon if you want. I wouldn't recommend that, but some people here in Santa Monica in particular do. Or you can write a book about it. In fact, this is actually a very interesting book. It mainly goes into the history of salt. And I'm going to touch on the history of salt. As you know, I love looking back and to say, where did we come from with regards to salt? So all of those statements are partially true. But one is definitely true, and that is that sodium and chloride are essential for life. There's absolutely no question. If you did not have sodium in your diet, you would not be able to survive. And part of that is because your blood has the same salt content. The sodium concentration is basically the same as the Pacific Ocean that's behind me here. And many evolutionary biologists believe that's because we came out of the primordial soup in the ocean, and our cells and our circulating bloodstream basically replicate salt water. So salt is absolutely required for life. In fact, it's so required for life, we have to go back and say, where did the word salt come from? For those of you who own an Oxford English dictionary, most of you don't because you look it up online now, but if you look in the OED, there are 4 pages of the word salt. It's one of the most number of pages for a word in the entire English language. And the original derivation of the word salt comes from Salus, who was the Roman goddess, and this is a women's symposium, so I guess it's appropriate that salt is named after a woman. She was the goddess of safety and well-being. But importantly, it wasn't just well-being of the individual, it was well-being of the Roman state as well. So wealth, prosperity, health of the nation, if you will, the Roman Empire. And in fact, that's why Emperor Nero here had a gold coin with his face on one side and Salus is on the other side, because it was important for Nero both to be personally wealthy and healthy, but also for the Roman state to maintain. And usually Salus is depicted, if you look in Roman iconography, as sitting with this bowl of libations indicating well-being. Later, about a few hundred years later, she would be holding a snake. And this snake, of course, is the Aesculapius. If you look at the symbol of the American Medical Association or a lot of other ones, it has a snake because of ancient mythology. This goddess actually was later expropriated 2,000 years later in a famous painting by Gustav Klimt. Same individual, Salus, the goddess of salt. Roman soldiers were hence paid in salt. And of course, this is where the word salary comes from, right? Because salt was such an important commodity. There were cities like Salzburg in Austria that are named after salt, because if you happened to live near a salt mine, that was like having an oil well a couple thousand years ago. Salt was difficult to procure, and hence there was a lot of wealth involved in salt, and the soldiers were thus paid in salt. If they didn't do a good job, they were paid less, and that's why the term "not worth somebody's salt" comes from. And hence salt has been used as a currency, and here are some of the currencies of salt. The one on the right actually was picked up in Africa in 1904, so as recently as 120 years ago, salt was still being used as coinage, basically. These briquettes of salt used as monetary commodities. So was salt money? Yes, it was. You know, the problem is money melts. You know, if you get this wet, you lose all your money. So it's sort of like cryptocurrency, I think. And then salt has a lot of religious aspects too. For the Catholics, the Roman Catholics in the audience, the grace and wisdom of Christ was actually exemplified by salt, which is why in the Bible they say salt of the earth. And salts have been used in in the Catholic religion for a long time at the time of baptisms, for example. And indeed, Da Vinci knew this. Here's one of the more famous paintings in the world, The Last Supper. Who's this person in The Last Supper? Some of you may recognize and can name all these saints. Well, that's Judas. And it turns out that Da Vinci depicted Judas with what's in front of him? It's spilled salt. And this is why when you heard if you spill salt, you need to throw some, because it's a portent of doom. And this was to indicate in the Last Supper that Judas was the one who would betray Jesus. But now we look at salt mainly as an additive to food. And one of the reasons food is so ubiquitous with salt, or salt is ubiquitous in these fast foods, is what I mentioned earlier, that this is where most of the instant taste benefit comes from. It's why salt in potato chips and Fritos and salt in McDonald's Quarter Pounders. And if you look at the sodium on the lower row here, what you see is that almost an entire day's worth of recommended salt intakes can be consumed in one easy meal at McDonald's. If you have a Quarter Pounder and then you throw in cheese and you throw in French fries, for example, you're going to exceed the amount of sodium that has been recommended. Now, I'm going to pick apart whether those recommendations are appropriate, but nonetheless, sodium is ubiquitous now because it's cheap, it's easy to find, and maybe that's good, maybe it's bad. Let's see if we can answer that. Is high salt ingestion, in fact, harmful to health, right? That's the question that we're going to try to answer. Well, you already saw a world map of obesity and things. Here's a world map of sodium intake. Now, sodium intake varies dramatically, and that gives us the opportunity as scientists to ask the question, if salt intake is so different around the world, are there places that have better health or worse health related to their sodium intake? Right? That seems like a fairly straightforward thing to do. You can see that there are certain parts of the world that have very low sodium intake. The lowest sodium intake, as I'll show you in a minute, are with Stone Age tribes people because they don't have access to salt mines and to supermarkets and things like that. The highest incidence of salt intake, the highest amount of salt intake in the world is in Asia. And in northern China, for example, the average sodium intake, not salt intake, sodium intake is 6,100 milligrams a day. Whereas in the Amazon, it's less than 1/100th of that amount. Okay? So we have a 100-fold difference in sodium intake around the world. And thus people have taken what I would consider the 35,000-foot approach, which is let's just look at sodium intake in Brazil and in Uganda and in China and Australia, whatever, and then plot a very simple metric. All-cause mortality in the vertical axis, sodium intake left to right going up. And what it looks like here is, if you just took the most simplistic view, is that low sodium intake is associated with higher death rates. Well, that's interesting. That's not kind of what we were expecting. But remember where the lowest sodium intakes were, right? The lowest sodium intakes are in Stone Age tribes people. They have an infant mortality rate of almost 50%. And hence, all-cause mortality in a low sodium country may have nothing to do with sodium intake, may have other things to do, just like you heard about socioeconomic and psychosocial. Maybe the sodium intake here is just a marker of something else, right? So if you just say death versus sodium, looks like you should be eating more sodium, not less, right? But maybe those data aren't accurate. How about if we look at life expectancy at birth? Same thing I just said, right? You live longer in societies that eat more salt. But is that because the societies are eating more salt, or is it because they're wealthier societies, or because they don't have childhood mortality? So people, and this is Franz Messerly in New York, who's done this and done this for decades. Let's look at people who make it to age 60 to get rid of this concept that maybe poor countries have higher childhood mortality. What about people who make it to age 60? If you then plot life expectancy versus sodium intake, you see a fairly flat line, but not really a signal that low sodium is associated with longer life, right? A little bit contradictory to what you might expect, or at least what the mantra is these days. And if you then get rid of some of the confounders like do you die of tuberculosis or malaria, here we're going to say, what's the likelihood of dying of a non-infectious cause? This is primarily cardiovascular disease and cancer. And then you look at these across all these countries, more than 50 countries around the world, you just don't see a relationship here between dying as an adult of heart disease or cancer versus sodium intake. Right? So why is it if you replot these, in blue is life expectancy and red is all-cause mortality, left to right is sodium intake, why is it that the Europeans, the ESC there, the World Health Organization in blue, or the American Heart Association in red, recommend those dotted lines as the salt intake that the sodium intake we should try to aspire to? Well, it looks like, if you just look at these graphs, they're trying to promote killing people, right? That's what it looks like. But these aren't dumb people. How could they take those data and come up with a recommendation that we eat less salt? And in fact, some WAGs, here's what they say. Here's where we are. Most industrialized countries in the world have a sodium intake of somewhere between 3,000 and 4,000 milligrams per day. The authorities want us to move down to 2,000 or less milligrams per day. Would that increase death? You know, are they trying to save Medicare money by killing all of us before we hit a certain age? I don't think so. But let's see where we could have gone astray. Are these data incorrect, correct? Are the people misled? Do they have ulterior motives? Well, first let's look at where they got the data about sodium intake. Most of the data on sodium intake do not measure sodium intake. What they do is you fill out a questionnaire of what you have for breakfast, what you have for lunch, what you have for dinner, and then they put it into a table and said, well, if you had 3 Big Macs, we know how much sodium is there, and if you had 2 yams, we know how much sodium is in that. And then they come up with an estimated amount. The problem with that is that, of course, around the world, how do you know whether people added salt? Did they add salt to the soup? Did they add salt on top of the corn on the cob, et cetera? That wasn't accounted for in a diet questionnaire. So right out of the gate, diet questionnaires are suspect in terms of their veracity with regards to how much sodium you eat. Furthermore, sodium intake is closely correlated with other things. You heard from Dr. Pappas about other things that influence cardiovascular mortality. This is a room of adults. Over half of us are going to die of cardiovascular disease. So if sodium has an impact on death, it's probably having that impact with cardiovascular events and death. And yet, if you look at what sodium is associated with here, large people eat more food, right? So if you weigh 300 pounds, you're going to eat a lot more calories than if you're 100 pounds. If you eat a lot more calories, what does that mean? It means you're eating a lot more sodium, right? So there could be a connection with eating more food means eating more salt, but if you eat more food, you get obese, and maybe it's the obesity that's causing cardiac events. So maybe the salt intake is just a marker. It's tagging along with food intake. Gender, men eat more salt than women. Is that why men have shorter lifespans? Maybe, hard to know. We know that older individuals eat less salt. Part of that is because the taste buds, if you will, become a little bit less active. It's why some of your older patients or maybe your parents want to add more salt because they can't taste the salt very well. And then social factors play an enormous role here. At least in the industrialized countries, poverty is associated with a much higher sodium intake. And hence you could argue that if somebody is just eating fast foods, for example, or they live in a food desert and they're eating more prepared foods that have high sodium, that maybe the marker of why they have a shorter lifespan if they're poor isn't because they're eating more salt, it's that they're poor. Maybe, right? And finally, there's this concept in medicine of reverse causation. So if sick people eat less, and sick people die more, if you're eating less sodium, so maybe eating less sodium was a marker of death because you're sick and you're not eating very much. Or conversely, maybe your physician, your nurse, your friends, your family says, don't eat much salt because you have heart failure and you can't eat as much salt. So if heart failure is associated with shorter lifespan, then a low sodium intake would be associated with higher death rates. And this is what confounds this whole field. That as simple a question is, how much salt should you eat, you'd think would be easy to answer. But let's look at the data. And most of these data are looking at cardiovascular events, like I've mentioned. I will just tell you, there is no strong signal that there are more cancer deaths associated with salt. So we're going to look mainly at the influence of sodium on cardiovascular events. And after all, high blood pressure is ubiquitous. If the average age in this audience is over 60, that means the majority of you are going to have elevated blood pressure. And that's where most of the focus has been for sodium intake. So let's look at the data about that. First, blood pressure rises with age. These data are from Argentina, but similar data from every industrialized country in the world. I guess you could argue whether Argentina is an industrialized country these days, but in the US, in Europe, Australia, Canada, et cetera, the blood pressure rises. Notice that it's only the systolic pressure in red that continues to rise as we age. The diastolic in yellow here does not rise once you hit age 50, and it's why the marker that we're going to look at is systolic pressure, not diastolic. You gain all the information you need from blood pressure just looking at the systolic pressure. You don't need to, in fact, the lower your diastolic pressure as an adult, if you have a low diastolic pressure, that's bad because it typically means you have stiff blood vessels. So let's look at systolic blood pressure in different parts of the world and in different sodium intakes. Here's a study that looked at 52 different countries, and within those countries, populations, okay? We're going to look first at blood pressure. Here's the average blood pressure of an adult in different parts of the world. So if you take 50-year-olds around the world, what you'll find is that 50-year-olds, like the Yanomamo Indians, which are a Brazilian tribe, or the Xingu, which is another Brazilian Amazonian tribe, the average blood pressure of an adult in those tribes is in the 90s. Whereas if you look at other countries that are sort of between industrialization and Stone Age tribes, the average blood pressure is 110. In most of the world, it's 120 at that age, and in the United States, it's even higher. So the blood pressure is different in different societies in the world. Is that because they have gene transplants when they move from the Amazonian jungle to Rio de Janeiro? I don't think so. What does strike us, though, is the blood pressure rise. And the lower right-hand part of this is the blood pressure rise around the world. For every 10 years of life, once you hit adulthood, on average in the world, the blood pressure goes up 5 millimeters of mercury. In you, because you're living in America, it's 8 millimeters of mercury, right? So we rise just under 1 millimeter of mercury per year. Whereas if you look at these other Stone Age tribes, they don't exhibit that. Their blood pressure remains what I call pediatric blood pressure their entire lives. So how is it that people who live in the Amazon have a blood pressure that remains the same from puberty to age 65, whereas here we don't? Well, much emphasis has been placed on the sodium intake of these different societies. So let's look at the sodium intake. The world's lowest, as I already mentioned, was the Yanomamo Indians. Their average ingestion, right, I told you northeastern China, it's 6,100 milligrams. It's 38 milligrams in the Yanomamo Indians. And when people tell me they need to eat at least 1,000 milligrams, well, these people live normal lives eating less than 50 milligrams of sodium per day. An even bigger difference, though, is, and I'll show you data about this in a moment, the sodium to potassium ratio. So sodium is mostly added to food. Potassium is found in vegetables, for example, and fruits. So if you eat a lot of fruits and vegetables and you don't have table salt, you don't eat a lot of meat and other things, you're going to have a high potassium diet and at the same time a low sodium diet. So one way to look at this is to say, what's the ratio of sodium to potassium in the diet? In the world today, the sodium to potassium ratio in various populations varies by 1,000-fold. So there are societies where the sodium-potassium ratio is 1,000-fold higher than other societies. And that may be a way to try to sort through this to say, well, maybe that will give us a hint as to what our diets and what our sodium intake should look like. This was exemplified, this problem here, by this famous photo from Yalta, February of 1945, right? Just before the end of World War II, when these three great leaders, Churchill and Roosevelt and Stalin got together, and what problem did they share besides having a war going on? They all had pretty bad high blood pressure, right? Those were the blood pressures on the day of the Yalta Conference. Now, back in 1945, I will tell you, they had no antihypertensive treatments, none, right? The first antihypertensive drug came out in 1956. So none of these leaders had the benefit of antihypertensive therapy, and maybe that's why they all died of stroke. Right? With Roosevelt dying soon after the Yalta Conference and Churchill and Stalin dying later, but all dying of strokes we believe related to hypertension. And I just want to put this one graph in here. The president had the advantage of having a White House physician. And the White House physician took his blood pressure twice daily, every day, and recorded it throughout the 4 terms of his presidency. And here's his blood pressure. And look at the day he died. The morning he had his fatal hemorrhagic stroke, his blood pressure was 300 over 190. Yeah. Pressures that you almost never see now, in part because we now have effective therapy. Okay. And that gets me to the point of how do we accurately measure blood pressure. You heard from Dr. Tadwalker of some of the difficulties, even with the simple signal of do you or do you not have atrial fibrillation, or how well is your sleep. You may not realize how technically challenging it is to measure blood pressure. And it was first described, pressure, in the 1600s, but nobody had any way to measure pressure in the 1600s other than palpating with your finger. Finally, in 1896, the Italians came up with measuring devices, and if you look at these, they look like smoke drums and various needles, and they just weren't ready for prime time. But the seminal observation came from a Russian in 1905, who, using a stethoscope, when he occluded the brachial artery, he could hear the blood starting to re-enter the artery as the blood pressure cuff was deflated. And that led to the seminal sphygmomanometer, which I actually have in my collection. If you come to Pacific Heart, you can look in my curiosities cabinet, and I have the original blood pressure cuff from 1911. It looks exactly like the blood pressure cuffs, not the ones they wheel in that are automated where you push a button, but the blood pressure cuffs that you and I have become used to using a stethoscope, et cetera. So we now have 111 years of blood pressure measuring ability, right? Shouldn't that have edified us about blood pressure? Well, it has to some extent. Here is a famous analysis, and blood pressure was first identified as a risk factor for cardiovascular events with the seminal Framingham data. Here is an American study that was after that, and this is called the Mr. Fit trial. But what it looks at is left to right is diastolic pressure, with the further to left being higher diastolic pressures, and from front to back are the systolic pressures. And what you see is that as systolic pressure goes up, the death rate from cardiovascular events or even all-cause mortality is substantially predicted by blood pressure. Now, in medicine, a correlation doesn't mean causality, right? So even though high blood pressure may portend death, it doesn't mean that lowering the pressure necessarily improves people, but we subsequently have documented that lowering pressures do indeed benefit people with high blood pressure. A couple of things I want to point out here. Many of you focus still on the diastolic pressure. That's not appropriate. If you look in the green bars here, what you see across the board, whether your diastolic is 100 on the left or less than 70 on the right, if your blood pressure is the typical adult pressure of 140 to 159, your diastolic pressure doesn't make any difference. If you have higher systolic pressure, the worst pressure you can have is to have a high systolic and a low diastolic, as I mentioned. So we're just going to look at systolic pressure and the effects of sodium restriction on this metric to determine whether that might help you and I avoid cardiovascular events. So here's the systolic pressure in America, and untreated, it's a very potent predictor of cardiovascular deaths. And if you look at the vertical axis here, there's a tenfold difference here in death rates. So a systolic pressure of 200, you're 10 times more likely to have a cardiovascular event than 110. Now the problem with these data is, who are the people on the left side of this graph? They're young people, right? Because as I've already mentioned, young people have lower pressures. Our pressure goes up 8 points per decade. And so the people on the right are all old people. You know, how many 20-year-olds die of heart attacks? Not too many. How many 80-year-olds? A lot. So these are not age adjusted necessarily. They try, and that's why it says age adjusted. But it's very, very difficult to subtract out age when you know there's a positive correlation between age and death rates. That's why we need better blood pressure measurements. And in 1940, the first description of taking blood pressures at home was published. And then in the 1960s, they developed ambulatory blood pressure monitors, which the Europeans have widely accepted. And indeed, 15 years ago, the Europeans stated that they won't even consider somebody as having high blood pressure unless the blood pressure is elevated outside of the medical environment. And this is because when you walk into a doctor's office, your blood pressure on average goes up 15 millimeters of mercury. Right? So it's very hard to then say, if the blood pressure is dynamic, what blood pressure do we use to advise us? Do you need a blood pressure pill? Do you need less sodium, more sodium? Let's look at the 24-hour blood pressure data to tell us, what does the normal blood pressure look like? This is a blood pressure high blood pressure drug trial on average. These are a bunch of data put together. But what you see is in the gray is the typical, for a high blood pressure individual, typical day-to-day variance of blood pressure, right? So your blood pressure is highest during the day. There are different peaks. It's highest when you first wake up in the morning. It drifts down a little bit. There's a second dinner time, a little bit goes up. And then as soon as you go to sleep, it goes down. It goes down at least 10%, usually more. And then it begins to rise prior to you waking up, right? So which blood pressure would we choose here as the blood pressure to determine should we recommend a medicine or salt restriction? Well, in yellow is somebody who was put on one blood pressure drug. In the turquoise color, put on 2 blood pressure drugs. And what you see is the blood pressure drugs move the entire thing down. On average, the typical blood pressure medicine, we have over 150 different remedies for blood pressure. They lower the blood pressure an average of 10 millimeters of mercury. Keep that number in mind, 10, because now we're going to look at what happens when you restrict sodium in these types of people. So here it is with restricting sodium. If you restrict sodium dramatically, okay, so look at the first group labeled Q1, quartile 1. They lowered their sodium intake by 5,900 milligrams. Well, if you're lowering at 5,900, you must have started above 6,000, right? So these are the biggest salt eaters in the world, versus quartile 5, where they reduced it by just under 1,000 milligrams a day. And what you see is that blood pressure, indeed, in these randomized trials, these are 12,000 trials, and they actually did the appropriate thing, which was not to do a diet questionnaire, but to collect urine, because if you eat 6,000 milligrams of sodium, you're going to excrete almost 6,000 milligrams of sodium. Some is lost in hair and skin and feces and things, but almost all of the sodium that you ingest will be excreted. So the best measurement is 24-hour urine collection. So these studies did that, and they randomly assigned people to eating salt, they're in the regular way, or going on a low-salt diet. Problem with some of these trials is they're very short. They're looking at blood pressure reduction in 1 week or 2 weeks. Very few of these studies are more than 30 days. So take that into consideration. But a blood pressure drug will lower your blood pressure within 2 weeks. What happens when you give sodium restriction? The average reduction is 4 millimeters of mercury. Yeah. And if you restrict only a little bit, the average reduction is around 3 millimeters of mercury. Now, most of us would argue 3 millimeters, I mean, that's not very much. A blood pressure drug is 10, but 3 for every day the rest of your life, or maybe 3 this year, but next year things change and maybe that same restriction would lead to 5 or 10 or 20. Maybe the Yamamano Indians who have a blood pressure of 95, the reason they're not 145 is because they've had a low sodium intake their whole lives. How do you test that? Very, very hard. Right? So let's look a little more into the details of this trial. If you want to look at all the data, the BMJ article reference is there, but here it is. I want to point out a few things. First of all, if you're young, now remember, young people have lower blood pressures to begin with, but salt restriction does not lower blood pressure in young people. Now maybe it'll lead to long-term benefits, we're not sure, but the older you are, you can see if you're over 55, you have a more robust response to sodium restriction than if you're under age 35. Right? What about baseline blood pressure? If your average blood pressure is low, and I don't know why there it is, thank you. If your average blood pressure is below 120, so that would be young people or healthy adults, sodium restriction does not lead to any blood pressure reduction that's measurable, right? However, the higher your blood pressure is, the more manifest your response is to sodium restriction. And there doesn't seem to be a variation based on your salt intake at baseline. So if you live in China and you eat 6,000, or you live in America, you eat 3,000, you get a similar blood pressure reduction if you, in fact, have salt restriction imposed. So those are the data looking from the large perspective, but it still doesn't answer the question of what should we recommend, right? What should we recommend for people? So here's an article that appeared in the last 12 months in the New England Journal, and this was an analysis that was relatively well designed. They took, and this is from China, and they took 600 villages in China, literally, and they randomly assigned half those villages, 300 of them, to substitute potassium chloride for table salt. Okay, so this does a salt substitute. Many of you may have been recommended to use salt substitute instead of sodium. So this is 21,000 people, but I want to point out who those 21,000 people were. They were adults. The average age was 65. Their baseline blood pressure was 154. 3/4 of them had prior stroke. 88% of them had overt high blood pressure. So this is a group of adults mostly post-stroke. A little different than if we were to recommend for this population what to do. And their average sodium intake was about 1/3 higher than America's, but lower than northern China. They had 4,300 milligrams per day as measured by urine. So here's what the study looked at. Let's take regular table salt on the right and instead give them salt shakers full of potassium chloride, but only 25% potassium because A, 100% potassium chloride tastes terrible. People won't eat it. And B, if you give too much potassium, you can kill people, right? That is how they execute people at San Quentin, is with potassium. So you don't want to give too much potassium to people. But they said, let's get rid of 1/4 of the salt added, right? Not salt in the foods. And if you look at those raw numbers there, did strokes go down when people were given potassium replacement? Yeah, they did. They went down 14%, which was highly statistically significant. And similarly, death rates went down. So it looks like, at least in this population, old people with strokes who had blood pressures in the 150s, that getting rid of some of the salt helped. However, there's a confounder here, and that is that you got rid of some salt, but what did you replace it with? You replaced it with potassium. And maybe potassium, in fact, has benefits. So maybe the benefit in this trial wasn't that you took salt away. Maybe it was because you added potassium, right? And how do you get rid of that confounder? It's impossible because that was what was looked at. Here are the curves for that. It doesn't look like there's a huge difference between regular salt and the salt substitute containing 1/4 potassium, but nonetheless, this is of some benefit. It's not as beneficial as blood pressure reduction with a blood pressure medicine, which lowers strokes to a much greater degree than manifest here. But at least there's a hint here that either potassium addition or sodium restriction, or both, it does lead to, in fact, some benefit, okay? And if you look in this particular trial at blood pressure, the average blood pressure fell by 3 millimeters of mercury, very similar to the other trials that I showed you. So some sodium restriction or potassium addition or both can blunt a little bit. But remember, their average blood pressure was 154. It went down to 151. Most of us in the medical treatment era would not consider that to be sufficient. Does this work by potassium intake increase? Well, this trial cannot answer that. Okay? It can't answer that. If you look in the upper one, you can see that urinary sodium went down, so the salt restriction did work. The lower graph is how much potassium was excreted in the urine, and that went up. So what this tells us is people did indeed use the salt substitute. They had more potassium in the urine, less sodium in the urine. So that's maybe helpful, but we're just not sure. So let's look at the article that led me to put this talk together. This is from 10 days ago. As I said, in our most prestigious journal, the New England Journal of Medicine. And this put together prospective, and I emphasize in the yellow down there, healthy adults. I'm going to show you in a minute what these people looked like at baseline, because that's crucial to determine whether salt and potassium make a difference, because these are healthy people. These aren't people that I would treat who come into me after having a stroke. This particular analysis used the best method we have, which is 24-hour urine collections, not questionnaires, and it used at least 2 of them so that you could get rid of day-to-day variation. Today I probably ate more salt because I'm going to eat 2 meals here than I would otherwise eat. So you have to have multiple days with which to compare. And these are 10,000 people followed for an average of almost 9 years. And they had a fairly typical American intake. 3,200 milligrams of sodium per day was their typical at baseline. And I suspect that's what most of you in this audience, depending on your body size, eat. Okay, so let's look at those analyses of relatively healthy people, and again, I'll show you who those people are in a minute. 24-hour urine excretion, so this mimics how much do you eat per day, versus the hazard ratio for cardiovascular disease. And notice that there is here a correlation, that if you eat more salt, at least as manifest in 24-hour urines, you have a higher incidence of cardiac events. And it's substantial if you compare the lower quartile that eats less than 2,000 to the upper quartile that's eating in the range of 5,000 milligrams per day. That's the sodium excretion. They also measured how much potassium, which is a surrogate for are you eating fruits and vegetables? Well, if you eat more fruits and vegetables and hence have more potassium in your diet, you have a lower cardiovascular event rate. Is that because the fruits and vegetables are saving you, or is it the potassium in the fruits and vegetables? You can't answer that from this particular study. The best indicator was the sodium to potassium excretion ratio. Less salt, more potassium, fewer deaths. And you can see it's almost half the number of deaths in the highest quartile. So is this just a reflection of diet, right? Healthy diets. You heard the word the DASH diet and other things. This is the Pritikin Center in another iteration. So does that kind of diet help people? Maybe. Does it help them by low sodium and high potassium? Maybe. We don't know. But let's look at who these people were. In these trials, here are the trials. Okay, look at the ages. They're mostly averaging in about 50 years of age. Look at the gender difference here, right? Some of these trials had a blend of men and women. Some were only men, some were only women. But if you look at the racial distribution or ethnicity, these trials were all of Caucasians. And if you look at the lower thing here, some of these trials, they all were college graduates. And why was that? It's because some of these trials only enrolled physicians or nurses, right? So if you then try to apply these data to the rest of America, these trials do not represent most Americans. 100% college graduates, who are Caucasian is not the typical American, and certainly not the typical representation of the world. Look at this top line here. If it comes up, and that's diabetes, right? How many of these people enrolled in these trials of low sodium were diabetic? 4%. Well, it's 25% diabetes in the patients I see in my practice. So if you take really healthy people, there's a benefit of a sodium-potassium change, but that doesn't necessarily mean that it will help sick people, and it's even possible that the sick people would have had a greater benefit. Don't know. That's the problem with these data. The other issue that we need to keep in mind is that all of the emphasis has been that sodium raises blood pressure, and hence if you lower sodium, you'll lower blood pressure, and that's the benefit of sodium. Well, that could be true or maybe not, because sodium affects lots of other things. If you take somebody who already has kidney disease and you force feed them sodium, and this is certainly true in animal models, you worsen them. We know that in parts of the world that eat lots of sodium, they have a higher incidence of gastric cancer, right, in particular. Some of the people have attributed that to soy sauce, actually. If you look at Helicobacter pylori, it's strongly associated with sodium intake. Turns out that osteoporosis is associated with, and that actually there's a biologic plausibility there because sodium and calcium interact in the body such that if you eat a lot of sodium, you end up losing calcium. So one of the reasons that in America that we have osteoporosis as we get older may be related to sodium intake. So that could be a potential benefit of salt restriction. I mentioned already that high sodium intake correlates with obesity, and you've heard about how bad obesity is. It also increases some of the neurohormones. Heart failure, my area of expertise, is amplified in terms of the effects of some of these hormones. And there is some preliminary evidence that high sodium diets turn on inflammation of the body. Interestingly, it turns out that high sodium also alters the gut flora. And there have been a lot of data recently that look at the bacteria in your gut. Turns out obese people have different bacteria than skinny people, and in animals, if you take a skinny rat and you do a fecal transplant into an obese rat, it makes the obese rat skinny, right? So the bacteria in the gut have a big influence, and in Cleveland, they're really hooked on this trimethylamine N-oxide compound, which is made by bacteria in the gut, and that amplifies cardiac disease. And it turns out if you eat a lot of salt, that substance by altering gut flora is increased. And that may be a link. It may have nothing to do with blood pressure. Don't know. Now, lastly, I want to talk about whether we should specifically recommend salt restriction in some of our patients, right? You've all heard that if you have heart failure, if you have edema, if you get admitted to St. John's today because you can't breathe and you have edema and you have cardiac dysfunction and you have what we call decompensated heart failure, should that person be told to eat less salt? It seems intuitive. But I will tell you that across the street over here at the RAND Corporation, where I participated in the heart failure guideline writing committee, when we looked at is there data to support restricting salt in individuals with heart failure? You'd be surprised at the paucity of data. So is it truth or is it fiction that we should restrict heart failure patients in terms of sodium? Well, let's look at a trial that actually tried to randomly assign people. Here's such a trial. They took people who had bona fide heart failure, symptomatic heart failure. These were people with ejection fractions of less than 40%, so we would call that reduced ejection fraction heart failure. This was an observational study, so it wasn't randomized, but they actually looked at people where they said, go home on a low sodium diet or not. And here are the curves over the next 3 years of the event rate of dying of cardiac disease or having a readmission to the hospital with heart failure. Okay, those are the two groups. Now, if you looked at those two groups, that's a big difference. And you might argue that, gee, well, look at salt restriction works. But it turns out, if you look at which group was restricted, it was the group that did worse, right? The red group, not what you would have thought. Because every nurse in this thing says, you got to go home on a low sodium diet. We know that because that's what the guidelines say. Well, what do the guidelines base that on? Here's a trial, and the trial said salt restriction didn't work. In fact, it was better if you allowed free access to salt, not restricted people with salt. This was so counterintuitive that the people who did this trial couldn't get it published. You know, that's part of the problem. There's a publishing bias. If you are on the outlying edge of science, you may not be able to get your article published. In fact, when you look at these data from that particular analysis, whether you're looking at death, hospitalization, it was mainly the heart failure hospital stay. And yet at our hospital, when people get admitted with decompensated heart failure, they're often sent home with a booklet that says reduce your sodium intake on the supposition that you might be helping those people, when in fact the data do not support that. If you look at the same analysis and ask, did it vary with men or women, young or old, you know, whether your ethnicity, whether you were less or more symptomatic, there really wasn't any group that stood out. Every data point here suggested that allowing free access to sodium actually helped people with heart failure, which is really interesting and hard to understand. And I mentioned, if we look at what does the rest of the literature say? So let's look at 2,000 different articles, and what do you find at the bottom here? What you find is, if you go through the analysis, even if you look at medical records of thousands of people, you go to the Medicare database, the slide didn't advance there. Yeah, keep going there, one more. And what you find is there are 0 studies. So we have guidelines, and we have booklets, and we have expert advice, all of which say eat less sodium, and that's based on no data, 0, right? None. It's just what people thought would be the right thing, and sometimes what you think is right is not right. And in fact, if you then look at more recent studies, here they are, and what you see is if you salt restrict people, look at these different trials. No difference, no difference, no difference. Favors actually, no difference, favors, no difference, no difference. Most of these trials, and they're very small trials, to have our whole society change on this database is probably inaccurate. So what I would submit to you is that there's no compelling evidence that salt restriction helps patients with heart failure. Now, how could that be the case? Well, I alluded to it a minute ago. Recent data have taught us that heart failure in particular, age as well, but heart failure in particular, people have altered sensitivity to salt. And quote, food doesn't taste good is what they'll usually tell you. And one of the big aspects of hearts is that if people become malnourished, they'll do worse with heart failure. So counterintuitively, if you give them foods that have salt in it, they're going to eat more food, which means they'll be less malnourished. And it could be as simple as that. Okay. There are other reasons as well, though. This is a depiction of the kidney. And it turns out for your kidney to get rid of water, and after all, congestive heart failure isn't an overload of sodium in the body, it's an overload of fluid in the body. So if you want to get rid of that fluid, how do you do it? You have to present salt to the kidney for your body to make urine, to get rid of that extra water. And that led some very bold people to do what I would consider a very interesting experiment, which is to say, okay, let's take those decompensated heart failure patients in our intensive care units who can't breathe because they're volume loaded, and let's give them salt. Right? And when I first started doing this, I would get calls immediately from the nurses saying, what are you doing, you know? Well, here's what We do. Right? Let's give what we call hypertonic saline, right? So normal saline, your body, et cetera, is just under 1% salt, 0.9% or thereabouts. So let's give high salt. And this is commonly done when people come in with the medical condition of low sodium, which is hyponatremia. But you can do this in heart failure patients, and if you give 3% salt, that's almost 4 times the concentration of salt. And then you just say, how did people do? Let's give some of them salt, let's not give the others this high sodium, and let's see what happens. Well, here's what happens when you do that. If you look at the line, the second line, all-cause death went down by half when you gave sodium to people who came in with decompensated heart failure. Hospital readmission went down by half. The length of hospital stay was shorter. This sounds like an administrator's dream, right? You get people out of the hospital sooner, they don't die, they don't have recurrence, they don't come back in 30 days, your hospital doesn't get penalized. And all you did was give them salt. Give them salt. There are the data, right? There are very few things that I can do in heart failure that reduce mortality by 50%. In fact, there are none in terms of medicines that have that kind of effect. And here all you're doing is giving them salt, which is weird. But that's what turns out to be the case. If you give them salt and you give them Lasix, which is furosemide, the kidneys wake up, they get rid of the extra fluid, they decompress the renal vein, which is an important thing to decompress in this scenario. And therefore, not only do you improve their signs and symptoms of heart failure, they get less symptomatic, they leave the hospital sooner, they diurese to a greater degree. So if you're following as a nurse, you're following how much urine output there was, you will double the urine output if you give hypertonic saline. And believe it or not, that then the kidneys are saved, because one of the problems in heart failure is as you diurese people, sometimes the blood tests we use for kidneys get worse, right? The creatinine goes up and people say, oh my God, I have to stop the medicines. I hear this all the time. Turns out if you give them sodium, the creatinine doesn't rise as you diurese them. And that leads to less mortality and less readmission. So the strange fact here is that giving salt may actually help people with decompensated heart failure because it allows them to free up this fluid. So I want to close by just saying that knowing the truth about salt is not rocket science. Right? It's actually way harder than rocket science, way harder. Rocket science is just math, you know. Anybody who takes care of patients knows it's not just math. And the reason for that is that studying populations is very, very hard. You can't do an experiment over 80 years of a person's life. You can't randomly assign people at birth to 1 gram of sodium the rest of your life or 6 grams of sodium the rest of your life. Can't do it. So you have to try to, using various statistical methods, go through this minefield. And the scientific method of just doing A or B and seeing which is better doesn't apply to these populations. So it's very hard to know the absolute truth. But what I will tell you is that not for the decompensated heart failure patient, but my review of the literature would strongly suggest that in fact data do support that there are population benefits, not individual, but population benefits of reducing salt intake. And that's mainly going to be through the food industry, right? Putting pressure to lower the Lay's potato chip sodium by 15%. Get rid of some of the sodium in pickles, whatever, pizza. By so doing, there have been populations that have done this, and I believe that will indeed lead to better health. And I thank you very much for your attention.